Support. My name is Arthur van Zanter. I'm an intensivist from Ede, the Netherlands, a professor at Wageningen University. Next to me is my co-chair, Dr. Annika Reintam-Blaser, both from Estonia and Switzerland. And we are happy to moderate this excellent session. At least we think it will be an excellent session because we have selected maybe the best speakers of the Congress during this last session of this Friday afternoon. And of course, targeting one of the most important topics in critical care medicine, that's metabolic support. And it's a great pleasure for me to announce the first speaker. That's Professor Greet van der Bergen from Leuven here in Belgium. She almost needs no introduction because she made this concept of tight glucose control very important in critical illness. And she will take us on her journey through the ups and downs of glucose control. Great, please, the floor is yours.
Thank you very much. Such a title makes you feel very old, because indeed my scientific journey through the ups and downs of blood glucose control is one of 22 years of research up till today. And I'm going to talk about this in 15 minutes, so it will be a bit condensed. But I'm just referring you to a paper that we just published in the Blue Journal, which is out in the March issue, which has the full story. So, as you all know, this journey started in 2001 with this publication in the New England Journal of Medicine, where we observed reduced mortality with tight glucose control. But the controversy, I mean, we're talking about it still, so the controversy continued for 22 years. And for those who weren't aware of why we started to do this study, well, there was this one observation well known already at that time, that hyperglycemia is associated with mortality. But we also, from our earlier work in endocrinology, had an observation that indicated that there was lack of insulin effect in the liver, indicated by high levels of IGF-BP1, which suggests lack of insulin effect in the liver, and that was very predictive for mortality as well. So if we took those two things together, that is why we had this design in our first RCT. We actually wanted to give as much insulin as possible. That was the hypothesis. And therefore, the lowest blood glucose, or the blood glucose level normal for age, which was the lowest risk of death, was our target, because that would be the maximum amount of insulin we could give. And in the control arm, we said, no insulin, preferably. Don't touch it unless the blood glucose exceeded the renal threshold. And so this is what we did. We did a surgical ICU study published in 2001 and then a medical ICU study published in 2006, the same study design. Patients were hyperglycemic upon admission, as you can see. They peaked on the first day, which we now know is related to nutrition. I will come back to that. And then we were able to separate the two groups well. They were only touching at the level of the whiskers, so they were very different. And it was identical in the two studies. This was a difficult thing to do at the time. And the method section of the paper reports several aspects of the methodology. How do we do this? And I'm just going to highlight a few. Like, at that time, the only tools that we had were actually strips for blood glucose measurements, which were really bad. And just before we started the study, we had the blood gas analyzer that came into our ICU, which had a very accurate tool to measure blood glucose. So that was important. We had all our nurses trained before we started to do the first RCT. This is essential. They have to be on board and do this right. And an important difference maybe with other countries and trials is that we were using early parenteral feeding to supplement insufficient enteral feeding, because that was what we were taught to do. And this was the result. I'm just pooling the two studies together. This was a meta-analysis, per patient meta-analysis that we did for the two studies together. And there was a mortality reduction, 4% absolute risk reduction in the intention to treat, and double the effect in the long-stay patients. We also had important morbidity benefits, a reduction in new kidney injury, and a reduction in polyneuropathy as diagnosed by EMG, which was quite dramatic. And of course, given that the hypothesis was either insulin effect, that was part of the hypothesis, or glucose control, we immediately set out in our animal model at that time to differentiate between the two things. What is now actually doing the job? And so we created an animal model of critical illness with two normal glycemic groups, one with normal insulin, one with high insulin, and two hyperglycemic groups, one with normal insulin, one with high insulin. And it is clear from this slide that it had nothing to do with the insulin. This was a blood glucose control effect. And the worst, the group that did worst was the hyperglycemic one with high insulin. This study was also done using parenteral feeding. That's something we have to note. So the combination of having high insulins and high blood glucoses was the worst. Then we did about a decade of basic research to further understand this mechanism. And I'm just summarizing, of course, because this has been a lot of publications. But it came down to hyperglycemia is toxic in the context of critical illness to those cells that take up glucose passively without need of insulin. So it's just concentration gradient dependent. Then we're talking about endothelial cells, white blood cells, hepatocytes, renal tubular cells, cells within the brain, being neurons or astrocytes. There was a slight effect on the heart from insulin and something on the dyslipidemia, but overall it was basically toxicity of hyperglycemia on the cells that take up glucose passively. But when we set out, we said we're going to give as much insulin as possible, so the normal blood glucose level, that would be the maximum amount of insulin to give, but we now know it wasn't insulin. So we said, is there a level in between that could also be good enough, because it's dangerous, as you know, to go very low. So we again looked at this pooled population and split the groups in 3 now. This is, of course, post hoc, with in green the severe hyperglycemia, in pink the in-between, and in yellow the tight to the normal glycemic level, and found that for mortality, indeed a lot could be gained from avoiding this very high excessive hyperglycemia. For kidney injury, it seemed like a linear dose response, more or less. And for polyneuropathy, it was necessary to go to the normal glycemia. So we then thought, well, we need to do it like that. But while we were doing all these mechanistic studies and trying to understand better, lots of other trials were done. And I'm just showing you a few. Some had some positive results. Most of them were neutral. The positive results, by the way, were mostly in the neuro ICU patient population, which is important also for later. And for those who are old enough to have seen this happen, there were some very lively, heated discussions at sessions like this in the past. I had to live with that. In the meantime, we were continuing, because also children in the ICU are hyperglycemic, and we have a very nice pediatric ICU as well. So we started to address that concept in the pediatric population with an even more challenging concept, because the normal for age blood glucose levels in infants and children are even lower than in adults. So we had to go even lower in our tight glucose control. The control group was hyperglycemic for their range, not so high as in the adults, but still for the normal range, yes, hyperglycemic. And we managed fairly well to bring them into control. Not as good as in the adults, I must say, but still, fairly well. We had, the study was powered for morbidity, because the mortality is low in pediatric ICU patients. We had shorter ICU stays, reduced inflammation, protection of the heart, and fewer infections, and much to our surprise, also a more mortality benefit. This is short-term mortality. We investigated the patients again 4 years after they were in the trial, and risk-adjusted, that mortality benefit was even maintained. So, and yet we had hypoglycemic events in these children. So, just to make that point. And we also investigated them cognitively, because, of course, if there is hypoglycemia and hyperglycemia, we needed to know whether there was harm, and there was no harm whatsoever. We had benefit on some of these neurocognitive functions, more specifically on executive functions, which are important in daily life. Then the day came that the bomb was dropped by the Australians. Indeed, this is the trial that then came, at least for me, as a surprise. The largest trial here, tight glucose control, showed to increase mortality, yet they did not observe differences in organ function. The deaths were cardiovascular, and they reported a hypoglycemia increase between 13 and 14-fold. And then a paper that they published later sort of attributed the harm possibly to the increased incidence of hypoglycemia. So we really had to, the data are always right, by the way. We have to learn from the studies and try to understand. So as compared with our studies, there were some more differences than this, but a few important ones. Targeting the control group was lower in eye sugar. The meters were not standardized, and as I mentioned, there were several instruments that were really not designed to go for such a blood glucose control. But two that I would like to address a bit further are the algorithm that they used, which was an if-then algorithm, not really very sophisticated, which may have related to the hypoglycemia, and then the role of parenteral feeding. So first, the algorithm. Like I said, our nurses were really trained. This was a setting where everybody was on board. And then we, very quickly after our first trials, set out with our engineers to develop a computer algorithm to make it easier for people to use in the ICU. And as you can see here in Leuven, we could really mimic what the nurses did. Actually better, because there was no hypoglycemia with that protocol. And we could export it to other centers, like, for example, here in another Belgian hospital, where they said they were doing as good as Leuven. We brought them exactly on the level that we did. So this without increasing the risk of hypoglycemia. So we thought that is going to be needed for exporting this concept to other centers. And then the next one is the parenteral feeding. We did our trials using parenteral feeding early, not based on good evidence, I must say, but that was what we did. And then this paper also came out showing that the log odds ratio of a mortality benefit with tight glucose control was related to the amount of calories given intravenously, with the benefit showed in the trials that gave the parenteral feeding early. So, when I was presenting predominantly also in endocrine society meetings, people said, well, is this glucose or is this parenteral nutrition? And we took that comment very seriously and subsequently did two other RCTs, multi-center RCTs, in adults and in children, where we just did the same thing, took away the early parenteral feeding and saw the outcomes. And not giving parenteral nutrition for 1 week in the ICU resulted in fewer infections, both in the adults and in the children, larger effect size in the children. Not giving parenteral nutrition early resulted in a higher likelihood of earlier life discharge without affecting the mortality. Again, larger effect size in the children than in the adults. And so if we put these steps together in one way of thinking, we started by giving early parenteral nutrition without blood glucose control, went to early parenteral nutrition with blood glucose control, so reduced mortality, reduced organ failure, then left out the early parenteral feeding. Mortality wasn't altered, and this was just enhanced recovery with the fewer infections. So they're different things, possibly synergistic, but different things. And also, and again, I'm summarizing on a cartoon here, a lot of experimental work that we did. Also, the underlying mechanisms are different. So critical illness through inflammation, hypoperfusion, hypoxia causes cell damage, mostly to mitochondria, as I already mentioned. And cell damage for patients to recover needs to be removed. And the most important removal system to do that is autophagy. And what we found was that hyperglycemia, severe hyperglycemia, makes the damage worse, but giving macronutrients, but also insulin, in fact, possibly, reduces the damage removal by suppressing autophagy. So you do harm on both sides. So we have to start again, because now that we know that, the question is, or was, what is the effect of tight glucose control, first with a tool that prevents potentially lethal hypoglycemia, and second, in the absence of early parenteral nutrition? Do we still have to do this? Because if you don't give parenteral nutrition, maybe the autophagy can deal with some form of hyperglycemia. So this is the results of the paper where Jan Gunst was the first author, the TGC FAST RCT, published in the New England Journal last year. We did not give early parenteral feeding for the first week, as you can see here. The blood glucoses in the two groups, randomized to tight or conventional, are completely different than in our previous trials. You see, in the control group, spontaneously there was this blood glucose that went much lower than the target that we set. Hence, the groups became very close together. The next week, when we started the parenteral feeding, then they separated again. So this is completely different than our first trial. And again, no hypoglycemia. This, of course, is due to the fact that we didn't give early parenteral feeding. And the result was the all-cause mortality was unaltered at all. No harm, but also no benefit. Except for a subgroup that we identified a priori, which was the neuro-ICU subgroup. We will further investigate that. Morbidity, the New England paper doesn't allow you to give p-values anymore. I'm showing them anyway. In the total study population, we had a small effect on morbidity, that is, protective effect on kidney and on liver function. We thought that effect may be small but relevant because people are looking for treatments to prevent and treat ACI, and we saw an effect. So I think it's still important to report. And if we looked at the long stayers, those that we could predict with an algorithm at admission, the effect was larger, but the effect was also present in the short stayers. So for us, this still means that if you can avoid hypoglycemia, this still has a morbidity effect in this multi-center trial. And if we reconcile all the evidence now at the end of my journey, I'm closing up, hypoglycemia, if it's severe, induces damage. Macronutrients make the hypoglycemia worse, much worse, and suppress the damage removal. So the real culprit, in my view, is the parenteral feeding. And I know a lot of people disagree with me, but this is really my conclusion. Because if you don't give it, the hypoglycemia is much less and you allow the damage to remove. And that brings me to the end of my journey, and I would like to make 3 more comments, I think, if I may. First, if you, as young investigators, start out on doing clinical research, take blood samples or tissue if you can, and study mechanisms, because if you have something that comes as a surprise, you should be able to understand what is happening. Second, don't give up. I mean, it's not about doing one trial and then have the answer. You have to understand before you take a concept into medicine. And the third is, please continue to do research in the future. Thank you.
Thank you. Thank you very much. Great, amazing work. It looks like all your papers have been published in the New England Journal of Medicine. It's fascinating, all the work you've done in Leuven with your group. And are there questions? There's a question in the front. They will bring a microphone. I have a first question. You studied a certain threshold or targets for blood glucose in several studies for all the patients. And we now more and more see during this Congress that there can be heterogeneity of treatment effect. Do you think by maybe reanalyzing your data that some groups can benefit more or may, on the other hand, may be harmed by tight glucose control? Yeah,
we actually incorporated that aspect into our last New England paper, where we a priori said we were going to do interaction analyses for subgroups that in the literature had suggested to behave differently, sepsis to name one, cardiac patients to name another, and the neuro group was also a specific subgroup that we really wanted to investigate whether they behave differently because of the data, the original publications, and because of the risk for the brain, right? So the brain is really a target organ that we should be careful with. But what we saw was that exactly that group had a benefit, a mortality benefit even, and, no harm whatsoever. So we think that if you can completely avoid the hypoglycemia with this tool and don't give parenteral feeding, they still be, and that may be because they get steroids and other medication that really pushes up the hypoglycemia in that subgroup, they may still benefit from this. Again, it's a subgroup, secondary endpoint. We shouldn't conclude that it is really the case, but it is important to note. So, but all the others, we really couldn't find. Okay. We're further investigating the long stayers in more detail. The diabetes we are going to study in more detail. But yeah, on average, there was not really treatment heterogeneity. We look forward for the next publications on this topic. There's a question in front here.
Hypo and hyperglycemia has got a deleterious effect, but do you think that there is a group of patients who has got a very fluctuating blood sugar and persistent hyperglycemia in the range of, say, 160 are not too bad unless someone has got 180, then 90 and having these fluctuations? Yeah. That can cause more harm than...
Yes, definitely, and that is why also the algorithm was used, the computer algorithm, because we really did not have that. We prevented the hypos, but we also prevented the large fluctuations because the algorithm really says, make an extra blood glucose control, and that allows you to prevent that. And in the last trial, we therefore did not see the harm. I think it's one of the aspects.
So did you both reduce the hyperglycemia, prevented the hypoglycemia, and reduced
the variability? Yeah. As compared to other protocols, if you see other studies that really, I mean, for our algorithm, we actually had the Amsterdam group in the study, and we found that they were really allowing these large fluctuations to occur, and that can also be prevented, absolutely.
Thank you very much. Amazing work. Sorry, I still got one question. Sorry. Do you think it's purely the route, or is it the dose effect regarding parenteral nutrition?
Yeah, that's a difficult one, but I think you ask my opinion. I think it is about the dose. It is the amount of macronutrients that you have in a condition where you can't use them. And so I think it's the amount rather than the route. And I think other trials have shown that the route only makes no difference, the British study. And it is, the problem is that you need to find when a patient is ready to use the macronutrients, but they're definitely, in my view, not ready, at least if they're critically ill enough for the first week in ICU.
Thank you very much. And we have a next excellent speaker, Jean-Charles Preiser, who is going to talk also about glucose, but now about new guidelines, right?
Thank you very much, Chairman, ladies and gentlemen. Thanks for staying in the Congress until the last afternoon. So I will summarize the discussions we had to develop the glycemic guidelines on glycemic control for adults and children. This was on behalf of the society, the American Society of Critical Care Medicine, and I was the only non-American participant to this to the elaboration of these guidelines. So I spent a few evenings on Zoom meetings to discuss all the different aspects. I have a few disclosures. So we had the task force with members who were either pharmacists, MD, intensivists, or also diabetologists. And we had also a few patients who participated into this the very interesting discussion. And we had, of course, a methodologist that was Kimia Onarment, who was responsible for the methodology. So these were some of the participants during the Phoenix Congress of the SCCM last January, and the recommendations were published in Critical Care Medicine in January this year after this long journey as well. So we, of course, knew that the TG FAST trial was ongoing during the elaboration and the discussions around the guidelines, but we had not the results at hand at the time of doing the meta-analysis. We know, as great reminders, that in critically ill patients who were not receiving early parenteral nutrition, tag glucose control did not affect the length of time that ICU care was needed or mortality. Still, we believe that the guidelines are consistent, are not contradicted by the data of this very important trial. So in terms of methodological considerations, we reviewed the literature. We had 22 panelists. Only six PICO questions were addressed. We had a systematic review of the literature from January 2000 until January 2023. We looked at the literature on the children, but not the neonates, and in adult patients. We used a great methodology, and the main analysis was focused on the all critically ill patients, and we planned subgroup analysis on mixed ICU, cardiac surgery, and neuro ICU. We used the language, which was defined accurately. So the strong recommendations were phrased as we recommend when the desirable effects of an intervention clearly outweigh the undesirable effects. This is the wording that we planned to use. The conditional recommendation was phrased as "we suggest" when the desirable effects were not clearly greater than the undesirable effects. So these were the recommendations. Thereafter, we got also statements, the good practice statements, clear and actionable, when we felt that even in the absence of robust evidence, the message was necessary. There was a net benefit large and unequivocal, but it was difficult to collect and summarize the evidence. The rationale should be explicit, and there was not graded according to the methodology. So these are good practice statements that were also published. And finally, the last type of recommendation we got is the in all practice statement, as we are experts. When evidence was insufficient to make formal recommendation, we wrote in all practice. We do like this. We developed this through a discussion among panelists to ascertain their current practice to avoid leaving people without any recommendation. It was only intended to describe the current practice of the panel members. So we prioritized the outcomes. Hospital mortality was the preferred one, and you can see that developmental outcomes was related, for instance, to children, of course, ICU mortality, quality of life, etc. So we prioritized, after a vote, these outcomes. So, which are the adult statements? We have 4 graded recommendations and 2 good practice statements. The first recommendation, in fact, is a statement, which is the glucose level to trigger an intervention, to start an intervention, and we found that the best trigger was 180 milligram per deciliter or 10 millimolar to initiate a protocol or procedure. In fact, the procedure could be the adjustment of glucose intake, nutritional support, concurrent medications, and add insulin therapy if persistent, meaning higher than 180 on 2 consecutive readings. And of course, we highlighted the fact that further research is needed, namely to address the optimal threshold to start blood glucose in patients with poorly controlled diabetes, for instance. Glycemic target range once the insulin infusion was started. Again, a good practice statement. Use protocols such as the Logic 1 or others with low risk of hypoglycemia and treat hypoglycemia without delay. The recommendation, here is a recommendation, a conditional one, suggests against titrating to a lower blood glucose target versus a higher target range. So in fact, we defined this target. Intensive was 80 to 140 versus conventional 140 to 200. This is a recommendation. So we looked at the risk of severe hypoglycemia without any surprise. On the first plot, we saw that there was an increase in the risk of hypoglycemia by a factor 3.75. No difference on hospital mortality to support our statements. The monitoring frequency, which is also an important practical aspect, we defined the blood glucose monitoring as frequent if it was if blood glucose was checked every hour or less than that, or continuous or near continuous monitoring systems, and infrequent when the interval between reading was more than 1 hour. We recommended frequent monitoring. It was a conditional recommendation with a low certainty of evidence. So there were a few data to suggest that the need for renal replacement therapy was improved with frequent monitoring, while the length of stay in the ICU was favored by less frequent monitoring, but these data are really on very small and irrelevant sample sizes. Administration method for insulin, infusion versus intermittent. The recommendation Again, for adults, we suggested continuous insulin infusion versus intermittent. It was a conditional recommendation with very low certainty of evidence. Now, for the children, we had a group of pediatricians led by Elie Erzberg. 2 graded recommendations, 2 good practice statements, and 2 in our practice statements. Glycemic target range, so the good practice statement was to use protocol with low risk of hypo and treat hypo without delay. The recommendation, and this is the only strong recommendation against titrating to a lower blood glucose target versus a higher. This was so a strong recommendation, but with a moderate certainty of evidence, with the same definition for intensive and conventional targets. Administration for children, infusion versus intermittent, no recommendation could be made. In the practice of the pediatric experts, they use continuous infusion. The monitoring frequency in children, same definition, no recommendation regarding frequency of blood glucose monitoring, but in our practice, in the practice of the pediatric expert panel members, they use the continuous or near continuous monitoring if available and of course reliable. The use of explicit decision support tool was supported. We suggest the use of these decision support tool, and it could be computer guided or not, where the explicit decisions to support tool has the following features, of course: explicit recommendations, reproducible actions, 2 or more patient-specific input variables, 2 or more output variables, so for instance, the rate of insulin infusion and the time for the next check, and open loop systems, as the closed loop systems are not yet available for clinical use in the ICU. So this is the summary, and this is also my last slide, so I think that there will be time for a few questions. So you have the white or rectangles. These are the good practice statements. We have the strong recommendation in dark green, the conditional recommendations in light green, and no recommendation, the yellow rectangle. So we can summarize: adults on the left and children on the right. Initiate glycemic management protocol to treat hyperglycemia above 180 milligram per deciliter, 1 to 10 millimolar. Use glycemic management protocol with low risk of hypoglycemia. Then for adults, suggest again a lower target range compared with a higher target, so target rather 140 to 200. Suggest once insulin is started. Suggest continuous infusion rather than intermittent. Suggest frequent monitoring. On the other side, for the children, recommend against a lower target, and this is a stronger recommendation than for adults. No recommendation regarding the route of insulin, just in our practice, as well as the monitoring frequency. And finally, they suggest the use of an explicit decision support tool for titration of insulin infusion. And you have the level of certainty also, which is represented by the number of plus for each box. I must say that at the end of this presentation, we have now the plan to perform an update of the meta-analysis, including, of course, the data from the TGC FAST trial. So thank you for your attention.
Thank you very much, Jean-Jacques. Are there questions in the audience? I have one question, maybe. The microphone will come to Professor van der Bergen. Jean-Jacques, I don't see a difference for patients with diabetes before ICU admission or non-diabetic patients. Did you address this topic, or should we go for the same targets?
In fact, no, a very good question. We have a lot of observational data showing that when the glycemic ratio, so the admission blood glucose divided by the average estimated ratio that we can calculate from the A1C, from a hemoglobin A1C, the survival of the patients had a better outcome when they were closer to the usual average blood glucose, so the glycemic ratio closer than 1. So this needs to be, of course, assessed prospectively. There is one trial, the controlling trial in France, that was stopped before the end because of a higher rate, an acceptable higher rate of hypoglycemia in the individualized arm, during the arm in which the blood glucose was the blood glucose target was calculated to achieve the glycemic ratio of 1. So there is a need for other trials, and we wrote that this was one of the highest priorities for future research, when using also algorithm with a low risk of hypoglycemia instead of the one that was used.
Professor van der Bergen.
Yes, Jean-Charles, I was a bit confused about the evidence of the trigger.
Of the trigger?
Yeah, the 10 millimolar trigger probably comes from the Australian trial, but it was never been compared to another trigger. So how can that be, saying that you should start insulin from 180 milligrams per deciliter, and why not 215? Or, I mean, that has never been compared, so I find this difficult to understand.
Well, this was not exactly the trigger to start insulin. It was a trigger that was just mentioned to start to lower blood glucose regardless of the strategy used. And indeed, this was mostly deducted from the NICE sugar trial. But indeed, this is a statement. So this is not. We recognize that this is not supported by robust evidence. This is a statement. We prefer to have statements instead of only recommendations supported by the evidence to help the practitioners, which are less familiar with the field. So it was a pragmatic decision to use the same trigger than the one used in ice sugar, to decrease blood glucose by any means, not only insulin.
Okay. There's another question. The microphone will be sent to you.
What are the recommendations for the patients in ICU that are not receiving artificial enteral nutrition, but they are on their own oral intake? Maybe they are there for doing non-invasive ventilation. Should we go on with the continuous infusion or what?
Well, in fact, the patients like this were included in the large interventional trials, including the one from Leuven and NICE sugar, glucontrol, and the others. And there was we didn't look at this subset of patients who were able to eat, if you wish, or were not fed continuously. In fact, the continuous insulin infusion is probably safer, as you can stop it if there is a hypo, or you can adapt the infusion rate, which is not the case if you give a bolus, of course. So, but this was not compared explicitly in the large trials. But indeed, this is a relevant comment. We prefer to stick to the evidence and to be as safe as possible.
Last comment by Professor Gunst over here in the front.
There is another.
I'm sorry, you are first. A short question, please.
A very fast question. Why is there no recommendation about how to measure glucose blood levels, either arterial or capillary or venous? Was there no data, or it wasn't a question asked during the guidelines processing?
Yeah, okay, thank you. Well, in fact, in Europe, we are used to use more arterial lines, which is much less the case in the US. And so I was the only non-American, so this was not in the list of questions because they are used to use venous samples.
But there's no specific recommendation on that. Professor
No.
Gunst in the front here.
Yes, thank you. It's actually not a question, just a comment on the previous question. So in the TC Fast trial and in the original trials, patients were excluded when they could eat upon admission. And we stopped the tight glucose control, if they were in the intervention group, of course, as soon as they were able to start eating, because it's very difficult to achieve tight glucose control in patients who are eating intermittently, because you cannot always have postprandial hyperglycemia, so it's very difficult to maintain them within a very tight range. So therefore,
and did you switch to intermittent then, or you kept continuing the continuous infusion? When they start eating?
When they started eating, we adopted a more liberal glucose target. We stopped the tight control.
Okay, we did not do that in the glucontrol trial. I don't think that was the case in the nice sugar either. So the target was kept the same.
Okay, thank you very much, Jean-Charles. Then we move on to the next speaker, Professor Rinaldo Boloma from Melbourne, Australia, and he will address the topic on SGLT2 inhibitors in ICU patients.
Thank you very much. I'm sure most of you are aware of the revolution in the management of diabetes in the chronic setting by the arrival of the sodium glucose cotransporter inhibitors. Their rationale was initially to make sure there would be glycosuria and therefore achieve a control of glucose that did not lead to hypoglycemia. However, they've now emerged as sort of extraordinary agents into treatment of diabetes and heart failure. The putative mechanism, of course, is that you block the sodium glucose cotransporter and you have loss of sodium and you have loss of glucose in the urine. This in turn has significant effects on the kidney, in particular it causes vasodilatation of the afferent arteriole via the macular densa effect, and it constricts the efferent arteriole and leads to changes. So it does that, and it causes changes in glomerular filtration. It has therefore significant effects at every level. It causes decreased hyperfiltration in the kidney, reduces blood pressure by sodium losses, reduces caloric intake by glucose losses, and it has significant effects at various levels that do not necessarily relate to the glucose losses in the urine by themselves. There's now been a plethora of large multi-center randomized controlled trials, which you see summarized there, all of which have shown significant benefits on mortality or the continued progression of kidney disease in the three main populations of CKD, diabetes, and congestive heart failure. Okay, so we're all happy. However, this is all in our patients. So these are people that are seen in the outpatient clinics and they are treated in this way. The perspective in acute medicine, however, has been different. In particular, there's been concern about the fact that these agents are associated with euglycemic diabetic ketoacidosis. And there have been a variety of case series in the literature. There's just one of them from the BJA showing that patients exposed to an acute illness or having surgery are at risk of developing euglycemic diabetic ketoacidosis in these patients because they're losing glucose, but at the same time, they're developing severe ketosis and they can be quite unwell in a way that is very similar to diabetic ketoacidosis. And there are a variety of triggers that have been reported in the literature that can acutely change the balance between ketone body's production and the body's ability to manage them, whilst at the same time not allowing the development of hyperglycemia. And of course, these case reports have led to significant concerns about the use of these agents in the hospital setting, let alone the ICU setting. More concerns have also come from the fact that these agents decrease GFR, and they do that in a chronic way that is protective ultimately against the progression of chronic kidney disease by decreasing hyperfiltration. But in the acute setting, they might contribute to acute kidney injury. This is one of the largest trials showing the benefits of this intervention in the longer term, but also showing that in the shorter term, a drug like dapagliflozin will be associated with a significant decrease in eGFR compared to placebo. And this has generated concerns in the acute setting as well. So what do the guidelines of the American Diabetes Society say? Don't do it. For me, that's the best invitation to do it. So, but other people have tried to take advantage of specific situations, and this is the DARE 19 trial by Koziborod, a cardiologist in the United States, who hypothesized that the administration of these agents might be protective in the setting of COVID-19 infection. Please note, these are not acutely ill patients in the ICU. They are hospitalized COVID-19 patients. And he randomized them to receive placebo or dapagliflozin. And this is a substantial trial, 1,200 patients. And what he found was that in this setting, there was no clear evidence of kidney decompensation. And if anything, the composite of kidney disease, acute kidney disease or acute kidney injury, and death from every cause was going in the direction of protection. This is another way of representing the mortality at time to event, which failed to achieve significance but was going in the right direction. And this is the cumulative estimate of the composite of AKI or start of RT or death. And you can see that the patients randomized to dapagliflozin showed a trend which failed to achieve significance in favor of a potential benefit with treatment with dapagliflozin. Can we find out more about what might be happening within the hospital community? And we looked at our institution using the EMR to see what was happening in terms of practice and to see if the use of sodium glucose co-transporters in hospitalized patients compared with dipeptopeptidase 4 inhibitors revealed any particular pattern in the direction of harm when sodium glucose co-transporters were used in the hospital setting. This is not a big study. There were 82 patients that had received the sodium glucose co-transporter inhibitors and 300 on dipeptopeptidases. So this is the ketosis, and the ketones you can see were more frequently elevated in the sodium glucose co-transporters inhibitor patients. This comes not as a surprise. It's the mechanism of action. That's one of the mechanisms of actions. And so that is not a surprise. But what we wanted to see was whether there was a significant association between this kind of ketosis and the presence of acidosis as measured by bicarbonate levels. And you can see that there wasn't really a signal in that direction. And as I often say to my fellows, my ketones in the morning, because I usually don't have breakfast, are probably around 3 or 4 anyway. And that's why I make such bad decisions. That's okay. So we then proceeded to a systematic review, which is under assessment, where we looked at all that was available about inpatient data for the use of these agents. And this is a forest plot of ketoacidosis events from various modeling and various studies showing that the incidence of significant ketotic events or ketoacidotic events is really not distinguishable in the in-hospital populations that have been studied with these agents. This is the forest plot of mortality events. Again, no significant difference, and perhaps in the heart failure patients, some evidence of benefit. And this is the forest plot for acute kidney injury. Again, quite a bit of heterogeneity, but no clear signal for studies that have involved only hospital inpatients to indicate a risk of acute kidney injury. So the information that we have now on a global scale by systematically analyzing the literature goes against kind of fear of these events. There have been more studies, very large systematic reviews looking at the risk of acute kidney injury from all sorts of large studies, and you can see that that just isn't there, and if anything, there's a potential benefit in these large multi-center randomized controlled trials. And looking at the adjusted and total changes in eGFR in these patients in the acute setting, in blue, you can see that there is no obvious major change to create concern. This is also a large data set in patients with diabetes that have acute kidney disease from Taiwan, using electronic medical records with 5,000 sodium glucose co-transporter inhibitors, and looking at the survival probability, but also looking at MAKE, the major adverse kidney events, in all sorts of subgroups. And of course, this is an observational data set. It's not a randomized controlled trial, but surely provides a sense of reassurance that the fear about acute kidney injury or acute kidney adverse events is unlikely to be associated with these agents. So emboldened by all of this, we started giving sodium glucose co-transporter inhibitors to ICU patients in a reckless act of madness. And so what we decided to do was to do an initial pilot feasibility study which is the equivalent to a phase 1 study in critical ill patients that had diabetes, type 2, were in the ICU, and we gave them these agents and wanted to see what the physiological effects might be in this population. And some physiological effects emerged. For example, the serum sodium went up, and you can see there was a clear difference over the period of observation of a week, which is likely consistent with a water diuresis induced by hyperglycosuria. And the reason I say that is you can also see the chloride going up consistent with that. There were no other obvious differences there. In the population that did not receive the sodium glucose co-transporter, time with the arrival of nutritional therapy by nasogastric feeding was associated with an increase in the use of insulin. The other population, despite an increase in nasogastric feeding, had a different pattern. And there was a clear, as I alluded to before, increase in diuresis. So if given to these patients in the ICU, you're giving a very significant diuretic, and mostly a water diuresis. Further emboldened by all of the activity, we have now applied for funding to do PREVENT AKI, which is a larger trial of using sodium glucose co-transporter inhibitors to aim to prevent acute kidney injury in a population at risk. This is a prospective multicenter parallel group double-blinded phase 3 trial, and we have just started recently in our vanguard phase of this trial and hope to be able to start in earnest later this year. So let me summarize by saying that we do not believe that the fears that exist about the acute use of these agents in hospitalized patients and indeed in ICU patients justify withholding these very promising agents that have been so powerful in the chronic population, and we're going to test whether we are right or wrong. Thank you very much for your attention.
Thank you very much, Rinaldo. Are there questions from the floor? There are some seats available in the front if you want to take a seat. Please welcome. Can you help us a little bit more with the pathophysiological mechanism you aim for in the critically ill developing AKI? Why this drug should help in that setting? Because the hyperfiltration in diabetes I can understand, but can you bring us back to the mechanism of AKI?
So we have a very limited understanding of what would happen in the acute setting because no one has actually done the physiology in the setting of acute critical illness. What we know is that this is a very nice diuretic. It's a water diuretic. It is likely that the patients will become hypernatremic if we're not careful, so there are risks associated with that. But we also know that it's likely to decrease oxygen consumption in the medulla because it's blocking all the work that the kidney has to do to reabsorb sodium. So the idea is that you might prevent medullary hypoxia by decreasing the work related to sodium transport.
And have there ever been studies with other substances like mannitol or something to prevent AKI? Because there are other ways or diuretics And I always understand that diuretics have not been shown to prevent AKI or...
Yeah. So in the diuretic environment, as you know, as you correctly said, mannitol, furosemide, we haven't seen anything like this. In this setting, there are animal studies showing an increase in medullary oxygenation with the administration of these agents. But no, we don't actually have any other evidence for that. Yeah.
Still no question. Maybe a last question. When you have such a patient with severe ketosis and acidosis associated with the use of these drugs, sometimes we see those patients in the ICU. Do you have some special guidance on how to treat those patients, or just give them glucose, insulin? What is your...
The typical response is the administration of glucose and insulin. You're absolutely correct. You're just assuming that, quite correctly, I think, that there is a need to move glucose into the cells and stop the ketotic drive. At another level, of course, there is a belief, and of course you cannot prove it because you can't really dissect and kind of remove that effect, that the change to a ketotic environment is a very powerful mechanism by which these drugs are helpful in the setting of chronic kidney disease or diabetes and congestive heart failure. Whether the change to a ketotic environment and a ketotic metabolic environment is helpful in the intensive care population is unknown.
It's unknown, but studied by several groups in the meantime, because they believe maybe it could be an alternative energy source.
Yes, of course. Yeah.
Well, thank you very much for your contribution. I think we are ahead by a few minutes in our schedule, but that's good during the last session because we want to close in time. And the next speaker is Professor Mervyn Singer from London, UK, and he will address diabetic ketoacidosis and should we go for a more rational treatment approach. Mervyn.
Thank you, Arthur. Hi everyone. Impressed at your stamina. Friday afternoon, good for you. Hypoglycemic? Maybe. Okay. It's not in my nature to be provocative, but these British guidelines are rubbish. Interestingly, when you look at the literature, there are like American ones which are about 18 years old, there are Canadian ones which are also old, and these are the only ones that are updated. I heard there's a European guideline coming, but it's not yet published. And this is what we're told to do in the UK, but how good are they? And when I read it through, I cry. Basically, they drown the fluid. They drown the patient. Do they need so much fluid? They give too much saline, so the patient gets a hypochloremic acidosis. They give too much insulin, so the patient ends up hypoglycemic and hypokalemic. And they confuse the poor junior doctor by having too many targets: ketones, glucose, pH, and potassium. So, and you can see they're quite simple. Okay, so yeah, we're all agreed, DKA, so you need by and large a high glucose, although obviously it's been a bit queered by euglycemic ketoacidosis with the SGLT inhibitors, a high ketone level and an acidosis, though again lack of knowledge of physiology. Oh, you can look at a venous pH. Yeah, but patients who are acidotic tend to hyperventilate, so the pH may actually be above 7.3 despite a significant metabolic acidosis. Oh dear. And they recommend all of these targets simultaneously. So you need to reduce your ketones by 0.5 millimole per litre per hour and increase bicarbonate and reduce blood glucose and keep the potassium stable. Quite a big ask, isn't it? Overcomplicated. So what do you prioritise? Do you lower the glucose smoothly but not too quickly? Do you lower the ketones as your primary target? Do you increase the bicarbonate as your primary target? So in the guidelines, they actually prioritise ketones. We'll come back to that later on. And I've sat down, I don't know in your institution, but in mine, the endocrinologists don't tend to do any acute medicine, so they come and see the patient 2 or 3 days later. But the patients need to be managed acutely. And, you challenge them. So, well, hang on a minute. If the ketones aren't dropping too quickly, but the glucose is dropping too fast, what do you do? And they go, that's a good point. And what happens if the glucose is dropping too quickly, but the acidosis is worsening? And they go, that's a good point. So I like pragmatic. What about the data underpinning ketones and this recommendation of dropping the ketones by 0.5 millimole per litre per hour? Yeah, clearly we want to get rid of the ketosis. It's part and parcel of DKA. However, how aggressive does it need to be? And that's the evidence. It's a big black hole. So, yeah, the resolution does depend on suppression of ketonemia. It means there's not enough insulin bringing the glucose into the cells, so the body uses fat instead, or more fat. And clearly, I'm not saying they're not useful to measure ketones, especially with euglycemic DKA, with the SGLT inhibitors. And so it can hasten the diagnosis. A patient comes in acidotic to the emergency department. The sugar may be normal or just a little bit high. Clearly, the ketones are useful, but often these patients, if they've been vomiting or starving or whatever, the ketones may be high for a non-diabetic reason. The blood ketone measurement, because it focuses on beta-hydroxybutyrate, is better than urinary, where you've got the metabolite acetoacetate as well. But I haven't found anything in the literature doing a trial comparing ketone monitoring as the primary target against a standard approach. And there's no data as to why do they pick 0.5? Just a nice number. That's as far as I can tell. So these are the different aspects. I'll just touch on them briefly, looking at the guidelines and saying why I think they're rubbish. Okay, blood pressure. Systolic below 90 on admission. Give them fluid. Okay, that's reasonable. And they suggest 0.5 to 1 litre in the first 20 to 30 minutes. And if they don't improve, ask for senior help. And if the blood pressure is above 90, you don't need to worry anymore. Well, hang on a minute. A lot of people may be elderly and they may have a normal blood pressure of 160 or whatever. Isn't 91 systolic, therefore you don't need to worry? Again, don't you look at the patient and assess if they're adequately perfused or not? So this very, I would argue, rather simplistic advice actually needs to be revised. And then you've got this horrible sort of kitchen recipe of drown the patient. A litre. On top of that, a litre in an hour, a litre in 2 hours, 2 hours, 4 hours, 4 hours, 6 hours. So then you're giving 6 litres in the next 19 hours. And it's comforting to know that reassessment of cardiovascular status at 12 hours is mandatory. Further fluid may be required. And you're thinking, well, hopefully they'll have looked at the patient before 12 hours. But it's a lot of fluid, isn't it? Does the patient need it? They may do, but the majority, I would argue, don't need it. And then they say once the glucose drops below 14, you still have to continue with this saline overload, but then on top of that, give 10% glucose at 125 mils an hour. So there's a further litre 8 hourly. Death by drowning. So again, it's not what we do with any other need for fluid. We give what the patient needs. If they're hypovolemic, hypoperfused, we resuscitate them. Half a litre, a litre, litre and a half, whatever they need. And then a more balanced approach. I'll touch on my views later on. And they advise a special input may be needed, special attention to these groups of patients. Elderly, pregnant, people 18 to 25 may get cerebral edema, heart or kidney failure, other serious comorbidities. So it's all right if you're 26. Why don't we do specialist input, well, not specialist input, but special attention for everybody? And then they discuss sodium chloride and compound sodium, Hartmann's, Ringer's, whatever you use, and they make the point that, yep, patients get overloaded with saline, hypochloremic metabolic acidosis that may cause problems. And it frightens me that, again, perhaps in the UK, I don't know about your places, but the average medical resident intern, they've drowned the patient with saline, they've got a hypochloremic acidosis, the patient's getting more acidotic, they ring the ICU, and they haven't actually recognised that it's iatrogenic because the body isn't used to intravenous chloride. We were never built to deal with that acute load. So the chloride shoots up, the patient becomes more acidotic. So it's often an iatrogenic problem caused by the guideline. And they recommend those salines. Saline's recommended because the trouble with compound Hartmann's, there's not enough potassium in it, there's a small amount, and it doesn't come with sort of larger amounts of potassium, and unfamiliar, not routinely kept on wards. Well, start using it, you know. You know, and so they recommend saline, yet they actually, this is don't rely on bicarbonate alone, because you may be causing hypochloremic acidosis that may have impacts on the kidney and may cause oliguria. Bit paradoxical. So they recognise there's a problem, yet they still recommend drown the patient with saline. So I would argue, hey, we know what's in a bag of fluid. Well, we should know what's in a bag of fluid, the constituents, they're drugs. So give whatever's needed. So you can make a good argument to actually look at the patient, their electrolytes, and give the fluid that's appropriate. And I've added there, often when we get these patients who have been drowned with saline, actually I think isotonic bicarbonate is often an appropriate drug. If the sodium isn't very elevated, it's normal, sometimes even low, bicarbonate's a good drug because you're not giving them yet more chloride. So again, just titrate according, or give according to the patient's electrolytes at that time. How much insulin? Again, they poison the patient with insulin. So infuse at a fixed rate of 0.1 units per kilo per hour. So an 80 kilo person, 8 units an hour, 192 units a day. That's a lot of insulin. Do they need that much? A lot of diabetics taking insulin don't use anywhere near that. So why do these patients need so much? And they recommend to reduce by 3 millimoles per litre per hour. And many patients, that's actually quite aggressive. And the fall's often much greater. So again, why not? Yes, I agree, let's have a gradual titration. We don't want very rapid shifts, potentially, osmolar shifts, potentially. It's rare, but recognise that you can get cerebral edema and so forth. So why not just have a gradual reduction where we're monitoring it and we can up or down the infusion rate to get that smooth reduction? Because if you give these large amounts of insulin, you will drop the potassium potentially too quickly. You will drop the glucose potentially too quickly. And as I mentioned, you may get these osmolar shifts. And they recognise the need to give potassium, and that often the potassium's high with the acidosis, but then it drops, and it can drop quite quickly. And I don't know in your countries, but in the UK, you know, there's restrictions on how you've got to give potassium in large volumes of fluid because, that's dangerous if you don't. And so then they get more potassium and then they get more fluid overloaded. Interestingly, they had a national survey following an earlier version of this guideline, which hadn't really changed that much, and they found that the rates of hypoglycemia were 27.6%, that's below 4, and hypokalemia 67%. And they're saying, well, it may have been that these occurred because you added in 10% glucose wasn't added in a timely manner, or the doctors weren't giving enough potassium. The main driver for both of these abnormalities is the use of insulin. Yet they still recommend 0.1 unit per kilo per hour. So if they recognise the problem, why don't they perhaps come down a little bit on the amount being recommended? So they do say once the glucose drops to 14, you can halve the rate. But, Why create a problem which they recognise? Don't know. So there are lots of other things. I won't go through these in any detail, but yeah, look for a cause. Infection driving it, heart attack, whatever. As I say, I don't give bicarbonate routinely. As I said, I only use it if I'm needing to adjust the electrolyte abnormality caused iatrogenically. Magnesium, they've often got the diuresis, they're hypomagnesemic. I'm a believer, I've debated with Jean-Charles, I never personally treat phosphate. They often go down with the insulin, the phosphate drops. Leave it alone, it'll come up again in a day or so, etc., etc. Sorry, I had to remove sodium shifts, not enough time. Okay, my Luddite way. Luddite is the old-fashioned way, before the Industrial Revolution came in the UK. But basically, just do what we do with any other sick patient. If they're hypovolemic, poorly perfused, resuscitate them quickly, repeated boluses of fluid, but don't just look at the blood pressure. And therefore, they don't need all of this litre an hour, litre an hour, litre in 2 hours thereafter. Just 150, 200 mils an hour is usually adequate. And if there is evidence of hypovolemia, hypoperfusion, give an added bolus. And saline, yep, you can start with saline, but keep an eye on the sodium and the chloride, and don't allow the patient to get a hypochloremic acidosis by giving more and more and more and more saline. The insulin, again, titrate to that target rather than just giving fixed doses, and modify the insulin rate. And yes, you'll need, especially if they've got DKA, to continue with the insulin afterwards. And obviously you can add in glucose, but you need to give the glucose on top of the saline. Hopefully, by the time you've got to this point, the patient's starting to eat and drink again. But again, you don't need much fluid. Yep, you can look at the ketone clearance, but I don't at all use it as a target of treatment. You should expect it to come down as you're giving the fluid, giving the insulin, giving the glucose. It will come down. Obviously, potassium, they are high, they can fall. Obviously, maintain normokalemia and just check. We have blood gas machines, we can check. I'll finish with this. With Bruno Bezen and Otavio Ranzani. So Bruno's in Brazil, Otavio's Brazilian, but he's in Barcelona. We did this thing in intensive care medicine last year where we highlighted, our views on management, which actually, independently before we started writing this or were asked to write it, they were actually very much in tandem, and that we've got there, 7 myths that are often propagated. I'll finish there. It's Friday afternoon. Hopefully you're still top left, but you may be bottom right, especially with too much Belgian beer. Thank you for listening.
Thank you very much for this challenging topic, Mervyn. Any questions from the audience?
And please feel free to disagree with me, please.
Well, we discussed this also in our group in the hospital. I think in the ICU, it's more easy to do this because we have all the tools to follow the patients. And in our hospital, severe diabetic ketoacidosis will be admitted to the ICU because of the frequency of measurements we have to do. But in the general ward, this assessment so frequently every hour or 30 minutes can be a challenge for the nursing staff and the doctors available there. What is your opinion about that? Is there a certain group that can be handled? Maybe this is too aggressive also, the guidelines for just general ward patients.
Yeah. But and sadly it wasn't quite ready, but we're doing an audit at the moment, looking back at the last 100 patients coming to the ICU to see how many were iatrogenic-induced admissions.
Yeah.
Hypochloremic acidosis, fluid overload, hypokalemia that they couldn't cope with on the ward. So it's one of these where, if the patient's fairly mild, then they can be treated on the ward, and you don't need to be that aggressive as these guidelines suggest. Whereas if they need more monitoring, perhaps they should be coming to the ICU in the first place. So I would argue that
Dependent on
it depends on the severity, and obviously if that patient has lots of comorbidity.
Question in the front here. Okay. I have a microphone. She's coming to. Maybe you can answer, why not resuscitate all the patients with Ringer's lactate or Hartmann with diabetic?
Yeah, you could do
it. We stopped saline.
You could do. As I said, there's this fixation on saline. You could equally well do that.
Jean-Charles, and then the microphone, please.
Just a quick question to connect with the previous talk. What about patients under SGLT2 inhibitors? Do you treat or do you recommend the same handling?
Yeah, well, essentially, yes. If they need fluid, give them fluid. A lot of the time, they don't need a lot of fluid. It's just a drug adverse reaction. And yes, they obviously with the SGLT inhibitors, they are glycosuric. And so they may have a diuresis, they may be hypovolemic. So, clearly just deal with that patient as they need. And you don't, again, same, I don't know, you're nodding in agreement. So you don't need, I think, to do anything different to what I've said. And clearly you want to look at the ketones and make sure that they go. But usually, in my experience with them, usually within a day or so, the half-life of the drug, the ketones have disappeared anyway.
Thank you. Last question here.
Yes, regarding fluid management, if we do have many a times patients with heart failure and very poor ejection fraction, then we are really scared about giving that amount of fluid.
100%.
So, and I know there are a lot of discussions over the fluid management. Do you think in that principle will be followed in diabetic ketoacidosis as well, or we need to push a little bit of more fluid, and how much more, that's gray areas. And second question, just regarding, every time we have been doing 1 hour, 2 hours of blood glucose monitoring. So it's become tedious, and do you think that once it achieved the 12 milliequivalent, then you can go from 1 hour to 2 hour or 4 hour, what? Yeah.
So your first question, I think, if the patient's got a significant comorbidity like heart failure, the last thing they need is all that fluid. So again, it's a good reason to get them to the ICU early rather than wait for them to have a big problem on the ward, potentially because of the way they've been given fluid, and you can monitor them. So again, just give the fluid the patient needs. They often will be hypovolemic and total body fluid negative. But again, you've just got to be careful to, obviously manage that comorbidity. The second point, yes, absolutely. If you're needing to, you often need to do a lot initially just to make sure the potassium's not dropping too much, the glucose isn't dropping too much, the acidosis is improving. But once they're stabilised, and hopefully by the time the sugar's down to normal or just a bit above normal levels, they'll be more awake, alert, eating, etc. And so, you can relax your monitoring frequency.
Thank you very much, Marvin.
Thank you.
So we move on to the next speaker. That's my co-chair, and Annika Ruijten-Blaser, and she will address the topic of vitamin C conflicting evidence. And she had some problems with her voice, so I hope she will manage to give the talk. Good luck, Annika.
Thank you so much. I hope so too. So vitamin C, conflicting evidence, disclosures. The lowest one here is important. I'm the author of the rapid practice guideline on vitamin C. And it's also important that I was invited to be a clinical chair of this guideline because I was completely naive towards vitamin C. I didn't do any trial on it. I didn't go into the mechanism of the molecule. So I'm sure in the room there are many people who know more about vitamin C, and I invite them to comment afterwards. Why vitamin C? This I had to find out then also. It's a water-soluble vitamin, we all know, body cannot synthesize it, so we probably need it. It's important physiological antioxidant, and it's required for several processes in the body. And hypothesis for studies or for sepsis in the ICU was that antioxidant properties of vitamin C may attenuate the systemic response to infection. So the rationale or hypothesis is there. Now we need to look at what is usually in physiology, oral vitamin C and intravenous vitamin C. The body is very tightly controlling vitamin C in our body, apparently. So if the intake is normal, let's say, then it's very efficient to absorb it and using it. If the doses go above 1 gram per day, then the absorption falls. So the body doesn't absorb it in this way anymore, and absorbed that unmetabolized ascorbic acid is excreted in the urine. And if you increase the plasma concentration, or if you take 5 times more vitamin C orally, then the plasma concentration actually only rises twice. They did pharmacokinetic modeling and looked at what happens with 3 grams every 4 hours of vitamin C, and achieved certain plasma concentrations, or predicted actually because it was modeling. 50 grams intravenously, peak plasma concentration modeling would be 13,400 micromoles per liter, which is many more fold higher than usual. And peak urine concentrations from intravenously administered vitamin C went up to 140 times compared to what they were with vitamin C, what was maximally tolerated orally. Vitamin C has been also studied in oncological research, and it is interesting because their kind of rationale was that if you give a lot of vitamin C, it also gets pro-oxidant role and is dangerous for tumor cells. So they wanted to kill tumor cells with vitamin C. And of course, that's why it came to intravenous administration, because orally you can forget it, it's not possible. And whether it is antioxidant or pro-oxidant is determined by several factors. But at least in oncology, it was considered, in oncology research, it is lower concentration, rather antioxidant, and higher concentration, more pro-oxidant. This is a review from our ICU people who do vitamin C research, and they collected several positive effects showed in mainly small studies for about more or less all the organ systems that you can imagine. Vitamin C in sepsis, now we come to the evidence. There are around 10 systematic reviews during the last few years. Amazing amount. Several of them found significant reduction of overall pooled mortality. There was also one recent study, probably there were more, but I was not able to find them, what was actually measuring oxidative stress, measuring whether vitamin C does what we think that it should do. And in this study, it was not confirmed that vitamin C reduced oxidative stress, but measured only with this one biomarker. And this is our guideline results of systematic review. And it was really very confusing to see mortality of 90 days here, showing absolute difference that is not significant but points towards harm. I don't know whether you see it. Well, you see it's red. And the lower ones in green are mortality 30 days. It is significantly towards beneficial. And mortality in hospital, it's towards benefit and without significance. So we were completely confused. What should we do now? And if we look at these forest plots, then here is 30 days mortality. The upper panel is always low risk of bias trials, and the lower panel is others, so high risk of bias trials. And you see here the effect, as already said, for 30 days mortality was significant in favor of vitamin C. Now we looked at in-hospital mortality. And now an interesting thing occurs. If you look at the upper panel with the low risk of bias trials, you see that that it is towards the right side, so favors no vitamin C. And if you look at the lower panel, then you see that it all comes to the left side, so it is in favor of vitamin C. And if we look at the 90 days mortality, which includes only low risk of bias trials, then you see that we are on the right side. And if you look at these trials and their 30-day mortality, then they are not on the side of in favor of vitamin C. So it was not that their 30 days mortality was better and then 90 days mortality suddenly higher. It was also important for us in the guideline that the largest study suggested harm from vitamin C in the composite outcome of death and or persistent organ dysfunction. And they also did Bayesian reanalysis of the Lovett trial and also showed very high probability of harm. And now we need to come to some kind of recommendation. We also looked at other outcomes, and you see it's mainly green. The only red thing that is against vitamin C was 90-day mortality. All the rest is on a green side. And this 90-day mortality, as you saw already, was based on 6 or 7 RCTs. So it was clear to us that we cannot make a strong recommendation. This we could decide. But it could be a weak recommendation in favor based on 30-day mortality and vasopressor duration, what was also significantly better. Or it could be a weak recommendation against, because we believe that it was important in low risk of bias trials to have 90 days mortality, even though the effect was not significant, right? And then we also thought what could be the mechanism for a drug to kind of improve the short-term mortality and impair longer-term mortality, and we didn't find it out. But we still also had to ask, if this would really be true, would it matter to patients? And we were actually not so good to answer it. However, there was one more important point before we came our recommendations. It was shown in several case series and case reports that if you administer intravenous vitamin C, then you cannot believe the glucose, what you measured with point-of-care glycometers. And here in this, you see that it was usually showing lower, but which is much more important and actually shown in several case series and case reports, that you have pseudo-hyperglycemia. And then you start treating pseudo-hyperglycemia, and this is dangerous for patients, obviously. And it's actually shown also in some summaries, and this is even systematic review, about the poor agreement of glycometer during vitamin C treatment. So we took this all together and formulated a recommendation against using vitamin C in adult patients with sepsis and septic shock. We commented that intravenous vitamin C probably does not impact long-term mortality. The evidence on early mortality seems due to small trials with high risk of bias. And we decided to go with better evidence, as good as we could. And we also felt it important that there might be another danger related to it, because usually glycometers, point of care, are used. And actually, Lovett trial investigators, they changed their practice to monitor blood glucose for the trial to avoid this aspect. We also had to say that maybe there are subgroups where we don't know whether it would be beneficial or not. But we also found this important argument that we should avoid any medication that is not clearly proven beneficial, because we give too many medications in the ICU and they also interact. And the reason not to give another one where we are not sure made kind of sense when making these guidelines. There are some evidence also after guidelines, Love It COVID and Remap CAP trials combined, and they stopped the trial earlier because triggers for harm and futility were met, and they didn't show beneficial effect of vitamin C, and there was high probability, very high for futility. If you look here, 99.9% and 90% probability for harm. And also an important piece of evidence coming after these guidelines, or during they were in process actually already, was that Victa's trial was another vitamin C trial where they also did long-term assessment and showed worse cognitive and psychological outcomes in vitamin C group. And so my summary is that pharmacological doses of vitamin C should not be used in routine clinical practice, but of course nutritional doses are needed because we cannot produce vitamin C, and this is important not to forget. Studies are still required, probably, but small single-center studies are discouraged. We shouldn't put more confusion in this evidence. And right population and right dose might be the question. And just to visualize this is a dose per kilo per day, what you see here on the slide. Thank you.
Thank you very much, Annika. You managed to give your talk excellently. We didn't notice you had any voice problems, so thank you for that. Any questions from the audience? Jean-Jacques, microphone will come to you. I have one question already. Did you look at whether they used ascorbic acid or sodium ascorbate? Because there's now some discussion on ascorbic acid inducing acidosis. That could be one of the mechanisms of harm.
No, we didn't. And we also must say that in many of these trials, you didn't get enough information. You didn't even have the dosage of vitamin C in some RCTs, and really basic information. So we didn't search for it, but I doubt that it would have been.
So we are
available.
comparing apples and oranges then. But Jean-Jacques.
Yes, please. Thank you. I'd like just to ask a very practical point. We know that patients being treated with continuous venous hemofiltration lose water-soluble vitamins. So would you keep the same recommendation for those patients with sepsis and CVVH, or would you recommend to give some vitamin C to compensate for the losses?
Yeah, I think compensating for losses would be reasonable, but I think this pharmacological dosing is not compensating for losses. So, but we also said that future trials are needed, whether we should give more vitamin C in these patients. But this is pharmacological intervention. Yeah.
Yes, I think you've clearly Murphy and Singer, please. Yeah.
Well, hi. Well, it's a question to Annika, and also Ari might want to comment too. Lovely talk, first of all. And yeah, I sort of share your worries. And I know Ronaldo, well, he's not here to defend it, but they're just about starting a sort of mega dose, much bigger doses of vitamin C. And it worries me that, well, hang on, if you're showing that signal to longer term harm, especially at a lower dose, are you sort of compounding it with mega dose? And, as I said, Ronaldo's not here. I don't know if Ari wants to comment or if you're aware of this trial. And I can't remember the exact doses, but they're much bigger.
Very high, but the difference what you asked is not the ascorbic acid.
Yeah, but why would that give the long term? Why would that give a long-term difference in outcome, ascorbic acid versus ascorbate? Because that's a short-term acidosis, but why would that give the 90-day signal?
Yeah.
Please, Ari.
Honestly, I'm not a specialist, Ronaldo is, but I think it's like in sheep models, the acidosis is really severe with ascorbic acid. So this is the hypothesis, but I agree with you to link this as an acidose of 5 hours with 90-day mortality. It's hard, yes. But this is why they want to do the trial. Yeah.
And I know there was one of these 10 systematic reviews or so where it was suggested that maybe higher dose is better than low dose, and maybe this also initiated next trials. Yeah.
Well, no more questions. Thank you very much, Annika. Then we move on to the last speaker, Ari Serpa-Neto from Armandale, Australia. Use of sodium bicarbonate in metabolic acidosis, please.
Thank you very much. Good afternoon. Thank you very much for staying until now. I promise I won't be long and you'll be soon free to have some beers. So I have no disclosure related to this presentation. So let's just start in discussing a bit the epidemiology of metabolic acidosis. And of course, you know that this is strongly correlated with the definition that we use. So we use this big Australian database, the adult patient database from NZICS, just to understand the epidemiology of two different definitions of acidosis. So first, the BICAR-ICU definition. We will discuss this trial in some minutes. It's more severe acidemia and acidosis, and something that we called 4 years ago as the NZICS criteria, which is basically mild, moderate acidosis. So the major difference is like pH of 7.3 against 7.2 in BICAR-ICU. BICAR-ICU used bicarbonate and also sulfa or lactate, and we just included the base excess, -4. So basically the prevalence, and this is really important in this data set, we only have data for the first 24 hours. So the ABG is just for 24 hours. So the incidence is probably much higher if we consider the whole course of the critical illness. But the prevalence of the BICAR-ICU acidosis in Australia and New Zealand was just 1.5%. And the prevalence of mild to moderate was 8.4%. The use of renal replacement therapy, which is really important in these studies now because there's some suggestions and some data suggesting that the use of bicarbonate could avoid renal replacement therapy, could reduce the use of renal replacement therapy. So 40% in patients with BICAR-ICU acidosis and 26% in patients with mild to moderate acidosis. And then mortality was 48% against 21.5%. The prevalence and the incidence of this mild to moderate acidosis is increasing in Australia and New Zealand. And of course, when we compare patients with mild to moderate against patients without any acidosis, the mortality is higher if you have even this, what we call mild acidosis. There is even another definition. This is from our French colleagues as part of the BICAR-ICU program, just patients with a pH less than 7.2. In their study, the prevalence was 6%. The use of renal replacement therapy was 20%, and the mortality was 57%. But I think the most important find from this study is that there was no association between the baseline pH level or the severity of the acidemia and mortality, but there was an association between the persistence of the acidosis in the first 3 days and mortality, and this is probably very important. So in summary, what we know is that metabolic acidosis is relatively common in ICU patients, potentially around 10 to 15% of critical ill patients, depending on the criterion used. Even mild to moderate acidosis is associated with poor outcomes, 20 to 25% of mortality in Australia and New Zealand. It's similar to sepsis, and in Australia, we are always really worried about sepsis. We want to do a lot of studies, we want to do a lot of things with sepsis, but we don't care about acidosis, and the mortality is the same, even when the acidosis is mild. And some data suggests that if we treat and if we revert the acidosis soon, and if we avoid the persistence of the acidosis, we can potentially improve patient outcomes. And what about the use of sodium bicarbonate? I know, you all know that the treatment of metabolic acidosis is the treatment of the underlying condition. But very often as clinicians, we use buffer solutions like sodium bicarbonate to treat the acidemia and the acidosis. And this is again the French study showing that in patients with more severe acidosis, pH less than 7.2, around 40% of the patients received at least one dose of sodium bicarbonate. And it's very nice to see this data, that the proportion of bicarbonate administration varied markedly, 5% in one side, 55% in another side. Predictors of the use of sodium bicarbonate. So the severity of the acidemia was not associated with the use of bicarbonate. However, there was a strongly association to bicarbonate levels and base excess levels, and the administration depended most on the center delivering the treatment. So it's not about patient characteristics, it's probably related with local protocols, clinician preferences, and center preferences. This is data using the MIMIC-3 in Boston, again, trying to mimic the BICAR ICU criteria. 29% of the patients with the BICAR ICU criteria in Boston received 1 dose of sodium bicarbonate. And in this study, the use of sodium bicarbonate was associated with a reduction in mortality when patients had AKI at least stage 2 and a pH less than 7.2, and maybe in patients with a pH less than 7.2 and a lactate greater than 2.2. But again, this is observational data. We did some retrospective studies in Australia, New Zealand, Japan, and Taiwan. And again, this is back to now the mild to moderate acidosis. Around 20 to 23% of the patients with mild to moderate received at least 1 dose of bicarbonate. Again, huge variation in practice. By site, 5% in one site, 78% of the patients with the same criteria received sodium bicarbonate. By country, 10% in Australia, 12% in Japan, 63% in Taiwan. Predictors, so higher Apache 3, lower pH, lower bicarb or base excess, higher lactate, patients receiving vasopressor or higher dose of vasopressor were all predictors for the use of sodium bicarbonate. And the characteristics, this is really nice to understand how we do. So basically, usually in this study, bicarbonate was used 2 hours from the diagnosis of metabolic acidosis with a solution with a median concentration of bicarbonate of 918 millimoles per liter, with a median infusion rate of 100 mL per hour, with a median total dose of bicarbonate of 110 millimoles, and 66% of the patients received boluses. 27% of the patients received a continuous infusion of bicarbonate, and 7% of the patients received both. And in this study, again, observational data, retrospective data, the use of sodium bicarbonate was possibly associated with a lower ICU mortality in patients with acidosis and shock, vasopressor dependence. But again, observational data, the significance was just borderline. And even different medical specialties, we treat differently. So lactic acidosis, if you are a nephrologist, you tend to use bicarbonate in 86% of the case, while if you are an intensivist, only 67% of the time. And even the threshold to indicate bicarbonate. So with a threshold of 7.1, 63% of the intensivists would give bicarbonate and only 40% of the nephrologists. The nephrologists in this study, they started the use of bicarbonate with a pH of 7.2. So even the specialty or the medical specialty makes things different. So again, it's not only about the patient. And this is a survey that we circulated among NZIC's CTG members, just asking about bicarbonate, the trial, the equipoise. And again, you can see that most of the clinicians and the members said that they would prefer to use bicarbonate in a continuous infusion, targeting just the pH, and doing more and more and more bicarbonate until you can correct the target here, the pH of 7.3. So we know that the use of sodium bicarbonate is highly heterogeneous. Around 20 to 40% of the patients with acidosis will receive at least 1 dose, and it's mainly driven by local preferences. What's the current evidence? Just one trial assessing the efficacy of sodium bicarbonate in patients with acidosis. This is the French BICAR ICU trial, beautiful trial, really important. 400 patients randomized, severe acidemia with a pH less than 7.2, PCO2 less than 45, and with sulfa at least of 4 or lactate of 2 or more. Patients, it's an open label trial, primary outcome was 28-day mortality. The author just found that the use of sodium bicarbonate was not associated with a reduction in 28-day mortality from a frequentist perspective with a p-value of 0.09, but you can clearly see a separation. Doing a quick Bayesian reanalysis of this trial, we just found that the probability of benefit is 96%, so very high. There was a reduction in the use of renal replacement therapy with the use of sodium bicarbonate in this population, and in patients that renal replacement therapy was started, it took almost 19 days for patients in the sodium bicarbonate to receive renal replacement therapy, against only 7 days in patients in the control arm. Of course, this can be confounded by the fact that the use of renal replacement therapy, one of the criteria was a pH less than 7.2, and if you give bicarbonate, you correct the pH, and probably you avoid some renal replacement therapy sessions. So sodium bicarbonate potentially improves outcomes. Even more if you have AKI. So this is a pre-specified subgroup analysis in patients with AKI stage 2 or 3. And in this pre-specified subgroup, the use of bicarbonate was associated with a reduction in the 28-day mortality with a p-value of 0.028. And in a Bayesian reanalysis, the probability of benefit was 99%, so very likely. So the equipoise is even less likely in patients with severe acidemia and AKI. And now the last update of the Surviving Sepsis campaign recommend the use of sodium bicarbonate for patients with septic shock, severe acidemia, and AKI stage 2 or 3. But this is a weak recommendation based on a low quality of evidence. It's just one trial in one country, and it's an open label trial. So what are the next steps? So we started in Australia one program of research to investigate the use of sodium bicarbonate in patients with mild to moderate acidosis in a blinded fashion. So this is the SODA-BIG pilot that we finished and published last year. So it's just a pilot to understand the feasibility and the way that our algorithm works. So we randomized 30 patients, 15 to sodium bicarbonate, 15 to dextrose, which was our placebo. We can discuss that. I know that it's controversial, but it's the best that we could do. You can see here that despite that we were using a pH of 7.3, with the addition of the base excess of -4, we were able to select a population that was like with a lactate of 2.3, 2.5, with a baseline SOF of 8, 9. So it was with a base excess close to -10. So the pH was not very low, it was 7.27, but it was still a sick population. We used an algorithm of 5 hours of infusion only, just to make things really simple. So just 5 hours of infusion, following an algorithm and a titration targeting pH and base excess. So it was feasible. Patients were randomized within the time frame that we wanted. The infusion was started within 1 hour of randomization. Basically, in patients randomized to the sodium bicarbonate group, the total sodium bicarbonate concentration used was 255 millimoles. The use of open label bicarbonate was just in one patient in the control arm, and the titration was followed. You can see here that with only 5 hours, we were able to correct the acidosis and the acidemia. So with 5 hours of infusion, we corrected the pH levels, the base excess, and the bicarbonate levels. And it took almost 3 days for patients in the control arm to achieve the same base excess, bicarbonate, pH level. So we basically we correct the acidosis 3 days earlier using just 5 hours of the infusion. The trial was not powered for like patient-centered outcomes. We were planning to randomize 60 patients, and we calculated our sample size to show an increase in the number of hours alive and free of vasopressor. But then we got funding we received funding from the government, and then we decided to proceed with the phase 3 study. So there's no statistically significant difference here, but you can clearly see that there's no signal for harm. There was even some numerical reductions in the duration of shock and vasopressor infusion with the use of bicarbonate. The mortality was really different, but it's a very small study. We cannot take any information from here, but it's safe. And then the probability of some benefit from a vasopressor perspective is really high. So we are just running now the SODA-BIG trial, the phase 3. We have now, today, we have 50 patients randomized. It's going well. And it's exactly the same as the pilot, but with the primary outcome of MAKE 30, which is death, 30-day mortality, receipt of renal replacement therapy, and persistent renal dysfunction. Our friends in the UK are also running a trial, the Mosaic trial. So it's very similar to SODA-BIG, but they now are using a pH of 7.3, but with patients with AKI. In our case, we are just randomizing patients following the acidosis. The patient doesn't need to have any AKI, but in the Mosaic, they are only including patients with AKI, and we already have several discussions with them to harmonize our CRF, our data set, and after we finish both trials, just follow with an IPDMA. Our French colleagues just finished the BICAR ICU2, which is really exciting. The BICAR ICU is very similar to the BICAR ICU1, but it's just in patients with acute and severe acute kidney injury stage 2 or 3, just to see if we can confirm the findings from the subgroup analysis. So in summary, metabolic acidosis is relatively common. Even with patients when they have mild acidosis, the outcomes, like the mortality is high, 25%. The persistence of acidosis is really associated with worse outcomes, so if we treat acidosis early, we probably can save some lives. The use of sodium bicarbonate is highly heterogeneous and mainly driven by local preferences, but we know that it can potentially improve outcomes in patients with severe acidemia, especially when AKI is present. And now we need to wait for our next studies to see if we can use in patients with mild or moderate acidemia and acidosis. Thank you very much.
Thank you very much, Ari. Are there questions in the audience? I have maybe a question. Did you also measure like CO2 levels? Because they can contribute to the acidosis? And secondly, do you believe there is a difference between AKI-driven metabolic acidosis, as there may be some kind of production of bicarbonate problem, versus intracellular production of acidosis due to sepsis or inflammation?
Yeah. So with the first question, in our case, we are limiting the PCO2 to 45 to include the patient in the trials. So only the patient, also the upper limit is 45. So this is really important. We are having some discussions if we should be more liberal, especially in patients receiving ventilation, because sometimes you're just using protective ventilation with some permissive hypercapnia. But at the moment, it's 45. And the second question, yes, I think the mechanism is different, and I also think that potential benefits of bicarbonate are also different if you have AKI, especially related to the indication and need of renal replacement therapy, and especially because in our experience, the most prevalent cause of acidosis is mainly septic shock, and in some cases, even drug-induced, like some patients receiving adrenaline, for example, and then you have the patients with some degree of acidosis because of the adrenaline. So definitely if you have AKI, you select a more severe population, it's probably you have a better.
Thank you. Question here?
Yes, Pirkka Pekkarinen from Helsinki, Finland. Hi, Ari.
Hello.
Could you comment on the sodium? When we correct acidosis with sodium bicarbonate, we give pretty much sodium to the patient.
Definitely. And this is something that we are always thinking about. Is it the correction of the acidosis with sodium bicarbonate? Is the sodium overload? Is the change in tonicity? Especially when you use 5% dextrose in the control arm, which is a hypotonic solution. So in the pilot trial, there was no difference in the sodium levels over the days. In our experience with the control arm with hypotonic 5% dextrose, the change in sodium is maximum at 1 point after the 5 hours infusion. But from the pilot, there was no difference in the incidence of hyponatremia or sodium levels, or even PCO2 levels. But again, only 30 patients in selected sites. So we need data from the phase 3 to understand, and then do some mediation analysis and some post-hoc ancillary studies to understand.
Okay, thank you very much, Ari.
Thank you very much.
So we have come to the end of this session. I think we had a great time with this metabolic support session. I would like to thank the speakers and you as the audience, the participants, and Professor Jean-Louis Vincent and Fabio Taccone for organizing this great meeting. And I hope to see you all back next year here in Brussels. Safe travels and see you. Bye-bye.